Good evening, all. So, the topic of discussion for today is Doppler in obstetrics. So, many of the postgraduates feel difficult to understand the concept and to apply it clinically. But let me tell you, this is a very important topic for us to understand and also to apply in our day-to-day lives. So, as you all know, Doppler is a very important investigation. We advise when there is a case of fetal growth restriction or when you're dealing with an Rh negative pregnancy, which is alloimmunized. So in these cases, we have to do an ultrasound along with Doppler for our decision making. Whether to continue the pregnancy or to deliver her is purely based on our Doppler findings. So I will be taking you through this topic under the following headings. So before going into the subject proper and its application in obstetrics, I want to highlight the importance of certain theoretical concepts which have deep-rooted, and these form the basic foundation for our clinical application. So we have to know what is the principle of Doppler, and that is Christian Doppler, who first introduced something called as Doppler effect, which I will be telling, and this forms the main basis for our Doppler, which we are using in our day-to-day practice. And also, I would like to tell you the types of Doppler and the Doppler studies available presently, and clinical application is our main agenda, and some of the practical aspects on how to use the Doppler on an ultrasound mission. So I can speak 100 things about Doppler, but if I don't know how to do a Doppler, it is of no use. And also some settings on the monitor are also important for us to understand to get a proper report. So this is the agenda for today. So what is this Doppler effect? So this Doppler effect is the apparent change in the frequency of either a light wave or a sound wave as the source of the wave is moving towards or away from the observer. So the observer might be stationary. So if the wave is moving towards the observer or away from the observer, there is some change in the frequency. So for a better understanding, the most common example which is given to describe this Doppler effect is a train. So you imagine yourself that you're standing in a railway station. So what happens when the train is approaching towards you? You hear that there is increase in the pitch of the sound in which the train is coming. And once the train leaves the station, then there is decrease in the pitch of the sound as it is leaving. But you have to observe that there are two important things. One, you are standing and you are a stationary object, you remember. So, and the train has the same sound, whether it is coming or going, it is traveling in the same speed. But when it is coming towards you, the pitch increases. When it's leaving from the station, the pitch decreases. So this is called the frequency shift. So the same principle is applied in the Doppler Doppler in which we use. So what is it? When the ultrasound beam falls over the vessel, there is some frequency in which it is entering. And when it goes and gets reflected over the RBCs, the frequency comes back. The reflected beam comes back. So there is change in the frequency of the transmitted beam and the reflected beam. So this is called as the frequency shift. And this frequency shift, it depends upon the velocity of the blood flow in which the RBCs are flowing. So I hope you understood. I will tell once again. So what is it? When the ultrasound beam is going and falling over or insulating over the blood vessel, it goes and just strikes the RBCs which are moving in the blood vessels. Once it strikes, the beam gets reflected, which is again taken by the machine. So there is a transmitted frequency and there is a reflected frequency. The frequency shift which occurs between these two is called the frequency shift or the Doppler frequency. And this is entirely dependent on the velocity of the blood flow or the velocity at which the RBCs are flowing inside the vessel. And so this is depicted in an equation form. So it is given as the Doppler frequency is 2 into the transmitted frequency into V. So what is V? It's the velocity of blood flow into the cos of theta. So what is this theta? It is the angle of incidence between the ultrasound beam and the direction of flow, and it is divided by C, that is the speed of sound in tissue, which is around 1540 meter per second. So this computes to the Doppler equation. So it is 2 into the transmitted frequency into the velocity of blood flow into cosine of the angle which is made between the ultrasound and the flow of blood divided by C, that is the speed of sound in tissue. So what happens to the Doppler frequency with respect to the angle of insunation? So if the angle of insunation is parallel, that if it is the theta is 0, then it will have maximum frequency. But what happens if the angle of insulation is perpendicular to the direction of flow? Then the cos of 90 is 0. So the frequency shift is 0. So that's why to get the correct Doppler measurements, we have to have an insunation angle which is almost parallel to the blood flow. So this angle correction, we need not worry. The preset mission will have this angle correction. So if this angle correction is not done properly, we will not be measuring the velocity of blood flow in a proper way. So this angle correction is very important for us to get the correct value of velocity of blood flow and the shift, that is the frequency shift. So in this picture, we can see that the A beam is aligned to the flow of the blood vessel. So we can see the Doppler wave which is formed down, the higher frequency wave is formed because the beam is aligned to the direction of blood flow. But now you see beam B. So this is less aligned and it is more of, it is not aligned to the blood flow. So the flow is this, but it is comparatively lower than the A wave. And now coming to the C wave. So this beam is almost perpendicular to the flow. So it is perpendicular to the direction of the blood vessel. So what will happen? The Doppler signal is very poor because cos theta, that is cos 90 is 0. So we are not getting the proper Doppler signal. And now you see beam D. The beam D, the flow is away from the beam and there is negative signal. So you have to remember two things. So if the wave, the flow wave is towards the beam, then you will get a positive wave. If the flow is away from the beam, you will get a negative signal. So in our routine practice, we cannot depend upon the frequency shift or because it's directly dependent on the cos theta. So we want to find something which is angle independent. So that's when this Doppler indices came into picture. So what is Doppler indices? These are angle independent. It's ratio. It's a ratio of two measurements. So that's when angle independent. We can rely on it better in our practice. So what is all this? Some tell what is systolic velocity, what is diastolic velocity, what is M. So these doubts you people generally have. So let me tell. So it is the wave which is formed during the systole, that is cardiac systole. There is a positive wave. So whenever there is flow in the blood vessel during the systole, that is the systolic velocity. If there is flow in the blood vessel during the diastole, that is called as diastolic velocity. If we take the mean velocity, it is called the time averaged mean velocity. That is systolic velocity by plus diastolic velocity divided by 2. So that is mean velocity in that particular blood vessel. So what are these indices? So there are three different indices. This one basic index called systole by diastole. It is nothing but the velocity of blood during systole divided by the velocity of blood during diastole. Next, a big index is the resistance index. So in this, there is systolic velocity minus diastolic velocity, again which is divided by systolic velocity. And the last one, which is the best, which can give us the better idea, is the pulsatility index. So this is very important because it has linear correlation with the resistance in the blood vessels. So higher resistance in the blood vessel, higher will be the pulsatility index. So what do you mean, madam? Why is this pulsatility index so much important in our practice? So you have to know whether there is resistance of blood flow when the blood is moving from the mother to the fetus. So fetus is getting all the blood from where? From its mother. So whether this blood flow is naturally happening or whether there is some turbulence or resistance to the blood which is received by the fetus is what we are concerned about and what we are interested about. So if there is more resistance, there is more pulsatility index. So pulsatility index is given by the formula systolic velocity minus diastolic velocity divided by timed average mean velocity. And why we are interested about Doppler indices? Because these have a clinical application and they are no angle dependent. They're angle independent, and that's why we can use routinely. And we have to know some little about what are the types of Doppler which are seen on our ultrasound machine. So we have something called as color Doppler. So what is color Doppler? Whenever you on the color Doppler, we can see the color of blood flow which is flowing. So if there is a vessel, it picks up color. So wherever there is blood vessel, it picks up color. So here a very important thing, please listen carefully. There are two colors which we commonly see when we switch on the color flow. That is, there is red color and there is blue color. So many of you think that red is for arteries and blue is for vein. This concept is completely wrong. So if you have understood that red is for arteries and blue is for veins, your concept is absolutely wrong. What you must understand is if the flow of blood is towards the transducer, the color which is depicted is red color. If the flow of blood is away from the transducer, the color which is seen is blue. So this depends upon the flow in the vessel and it does not depend upon the whether it is an artery or vein. So if you see both, if you focus on the umbilical cord, you have the umbilical artery and umbilical vein. So how will you identify? It is not based on the color. It is not based whether it is artery, whether it is red or blue. It is mainly dependent whether it is pulsatile. So usually arteries are pulsatile. So when you put the flow, if there is pulsatile flow, that is an artery. So even if it is taken up blue color, it is still an artery because blue is not telling that it's an artery or vein. It's just telling that the blood flow is moving away from the transducer. So this is a very important thing and it's a very basic thing that you have to understand. So this is the color flow Doppler. Next, coming to the Doppler. So wave. So how can the wave, if you put the color flow, you will just see the vessels. But to see the waveform, whether what is the systolic velocity, what is the diastolic velocity, how is PI done, and PI we can do a manual tracing or we have an auto trace which is available in all high-end machines. So that also is important to see the waveform. So pulse Doppler or spectral Doppler is one and the same. So we have a gate. So this gate you place it on the vessel and you will see the waveform. So this is called as a pulse wave Doppler. And the last one, that is the third one, is something called as the power Doppler. So it is power, it mainly is based, it gives importance on the amplitude of the Doppler signal. So these deeper vessels which cannot take blood, which cannot take color from the color Doppler because the wave has to insulate the deeper tissues and take up the color. So this wave has a higher intensity. So it penetrates through the soft tissue and it can go and identify the deeper vessels. So this is called as a power Doppler, and this usually has a unidirectional, like it has a single color. It cannot it cannot tell whether it is towards the probe or away from the probe. But recently there is something called as a bidirectional power Doppler also. So it is also called as the color power angiography, which detects the deeper vessels with low signals. Now the most important part. So how do we identify? How do we do the Doppler? So this is the practical application on how we actually do the Doppler. So in this class, I will just explain on how we do, and in my further videos, I will demonstrate on a live patient how do we actually measure and what are the settings. But for today's class, let me tell you how do you do. So usually the uterine artery we have to focus. So in the first trimester, we can just keep the ultrasound probe at the level just lateral to the pubic symphysis. So lateral to the pubic symphysis, if we keep, we will be able to identify the isthmus. And then if we put color, we will be able to see the uterine artery which is going towards the uterus. And if we put the pulse wave, then we will get this picture. So this is the waveform of uterine artery Doppler in the first trimester. But what about the second and third trimester? So as the gravid uterus grows, the uterine artery will be most laterally placed. So that time we have to take 2/3 and 1/3. So usually parallel to the inguinal region, we have to place the probe. Just the probe should be facing the umbilicus, and 2/3 and 1/3 of the inguinal canal we have to place, and then we can identify the pulsatile uterine artery, and we can do the measurement, and then we can see whether it has a diastolic notch or not. And sometimes we will do, not sometimes, all the time, we have to do something called as the mean pulsatility index. So usually pulsatility index of uterine artery is measured when doing a NT scan, that is between 11 weeks to 13.6 weeks of gestation. So why do we do a uterine artery PI? So you measure the right uterine artery PI, left uterine artery PI, and you divide it by 2. And if the mean uterine artery PI is more 95th percentile, then she is at a higher risk of development of preeclampsia. So you want to start with aspirin, because this is one of the preventive factor for prevention of preeclampsia. And uterine artery Doppler is a very important predictor of preeclampsia. And what about diastolic notch which is present? So if diastolic notch is present in the first trimester, it is absolutely normal. But if it's persistent in even in the anomaly scan, that is when you are concerned. So if there is persistent diastolic notch, or if the uterine artery mean PI is more than 95th percentile, these patients are at a high risk of development of preeclampsia. So this is the best predictor for preeclampsia. Now coming to the fetal vessels which we are interested. So what are the fetal vessels which we are interested? There are 4 vessels. One is the umbilical artery, second one is the middle cerebral artery, third one is the ductus venosus, and fourth one is aortic isthmus, and the last one is umbilical vein. So umbilical artery, how do you measure the pulsatility index? Go and Go identify free loop of cord. So you identify how you measure the amniotic fluid index. So at the lateral part of each quadrant. So there are free loops which are present of the umbilical cord. You have to not measure umbilical artery Doppler at the fetal end or the placental end, as the resistance is slightly higher. So we always identify a free loop, color Doppler, and measure with a pulse Doppler. So whether we see, so this is a normal waveform of an umbilical artery. So there is systolic velocity, there is a diastolic velocity. So even during cardiac diastole, there is a amount of velocity which is going to the fetus, so that the fetus doesn't go for acidosis. So what happens? As the fetal resistance increases, or as if the baby is going into fetal growth restriction and it is going into a decompensated stage, the diastolic velocity goes on decreasing. So then we can have something called as reduced diastolic flow absent diastolic flow, and reverse diastolic flow. So these are the pathological variants of the umbilical artery Doppler. So this image shows that there is decreased diastolic flow on the first image, absent diastolic flow on the second graph, and the last waveform shows that there is reversal in the flow during diastole. So this is called as REDF, reversal of end diastolic flow of umbilical artery. Next, we move on to the middle cerebral artery. So why we have selected middle cerebral artery? Because this is the artery which has maximum flow rate into the cerebral circulation. So how do we measure? First, we have to focus on the BPD plane. Then we have to move the probe or move the transducer such that we focus on the base of the skull. Then we switch on the color flow and we see the beautiful that middle cerebral artery which we see. We identify it and we place the pulse Doppler over it. Then we get a beautiful waveform. So if the resistance of the middle cerebral artery is decreased, there is a problem. That means the blood flow from the periphery is moved towards the brain. So this is called as centralization of blood flow. So when the baby is going into distress or the baby is going into growth restriction, what happens? The all other blood, the peripheral blood wants to go and supply to the target organs. So even in fetal anemia, it wants to go and supply to the main organs, the brain. So the blood flow from the periphery move towards the brain. So that's why if the pulsatility index less than 5th percentile in a middle cerebral artery, that means that the fetus is going in growth restriction. So in this image, the second image shows the BPD plane and it shows the circle of Willis. So here beautifully MCA is seen, and when we put the waveform, see the A form is a normal waveform where the diastolic flow is slightly normal, but the diastolic flow is increased in the B form. So there is increase in the end diastolic velocity. That means the baby is going in hypoxemia. The baby is it is called as the brain sparing effect. That is, all the peripheral blood is moving into the cerebral circulation. So now we know something called as CPR. They will tell CPR reversal, CPR is abnormal. So what is that? So cerebro, that is MCAPI divided by placental, that is umbilical artery PI, gives rise to this something called as cerebroplacental ratio. So if the cerebroplacental ratio falls less than 5th percentile, then also it is pathological. So these Dopplers, we cannot tell that this pulsatile index or the ratio has to be this value because it is not constant and it is dependent on the gestational age. So all these Doppler parameters, whether it could be umbilical artery PI or MCA PI or cerebral placental ratio, it all has a Doppler normograms. So this shows in percentiles whether this value is normal for that particular gestational age. So for example, at 37 weeks of gestation, 1 is the normal cerebroplacental ratio. So if it is less than 1, then it is definitely pathological. Moving on to the ductus venosus Doppler. So this is very important and it has 3 waves. So what are those 3 waves? It is an S wave, the ventricular contraction, the velocity during ventricular contraction. What is D wave? During the end diastole. And what is A wave? It's the atrial or the atrial systole which occurs at the end of diastole. So S, D and A wave are very important in a ductus venosus waveform. So if there is reduction in flow of A wave, then that means that atrial systole, that positive flow is not occurring. So if there is reversal of A wave, that means the baby is going into distress. And one more important thing, how to measure the ductus venosus waveform. So we have to focus on the abdominal circumference plane. We have to do the transverse section, and then we have to put the color flow, and the ductus venosus is coming out from the umbilical vein and it is going up. So the flow with the vessel which is taking more turbulent flow, that is the highest Doppler signal which is emitting, is the ductus venosus waveform. So then, so I have told you this in the previous slide itself, that is the first one is the normal, which has S wave, V wave, or the D wave and A wave. Then next there is an absent A wave. Next there is a reversed A wave, and there are certain other pathological abnormalities which are seen in the ductus venosus fluid. Next, the aortic isthmus, which is very difficult to measure in a clinical practice. It can be done. So, what is isthmus, or what is this aortic isthmus? So, you can see in that image C, you observe that is the place where the ductus arteriosus is meeting the aorta just before the aortic arch. So, just between the left subclavian artery and the ductus and the descending aorta, the ductus arteriosus is meeting. So this is called the aortic isthmus. So if there is reversal of flow in the aortic isthmus, that means the baby is going into impending distress. So the baby might go into death, or it is under, it's called as a pre-terminal event. So the baby might succumb in 1 or 2 days. So it is very important factor. So this is the last Doppler, which gives us the immediate termination. It gives us immediate signal to termination of the pregnancy. And next, coming to the venous Doppler. So usually the umbilical veins in a normal type, it will not be any pulsations. So it will be a clean wave. But if there is pulse venous Doppler, that means it is definitely abnormal. So after understanding in detail about how to do a Doppler, what is its importance, definitely clinical implication is important, because how much ever theory I speak, we are not bothered, but we have to know why is it indicated, why I have to know about Doppler. So that is very important. So what are the indications? So usually we have to monitor or serially surveillance of growth of the baby is important. So especially when you have a doubt that this baby might go into SGA or FGR, we have to do a routine surveillance. So this is from the guideline or GTG of SGA and FGR. Do a clinical risk assessment at booking visit and every visit when she comes for an antenatal checkup. So that's the booking assessment where we assess the minor risk factors and major risk factors. So if there are 3 or more minor risk factors or 1 or more major risk factors, we have to reassess at 20 weeks. So at 20 weeks, if we do a uterine artery Doppler, if it's normal, we can just assess the fetal size and umbilical artery Doppler in the third trimester. What if the uterine artery Doppler is abnormal? That is, if the mean PI of uterine artery Doppler is more than 90th percentile, then serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks is very important. So we have to serially assess whether baby is going in FGR or not. So when we do these serial scans and Dopplers, so we'll do 2 important things. One, the fetal biometry. The second one, the AFI. The third one is the Doppler. So based on this, we can manage FGR pregnancies. So this is a very important criteria. So this is a Figaro's and Gratico's staging of IFGR, which is very important in real-time situations. So there is a stage-based classification. So what is the first stage? It is just the smallness of the baby and the placental insufficiency is mild. So what is the criteria? If the estimated fetal weight is less than a centile or if the CPR is less than 5th percentile, or umbilical artery PI is more than 95th percentile, or MCA PI is less than 5th percentile, or uterine artery PI is more than 95th percentile. When you should monitor? Serially, every week you have to get Doppler done. When you should deliver? After 37 weeks. So let me tell one basic thing, that if the estimated fetal weight is less than percentile without any Doppler changes, it is called as small for gestational age baby. But if the estimated fetal weight is less than third percentile, or if the estimated fetal weight is less than percentile along with Doppler changes, it is called as fetal growth restriction. So for all SGA babies and FGR babies, this first stage, if they belong to the first stage, we have to deliver by 37 weeks. There is no point in continuing the pregnancy beyond 37 weeks. This is a very important take-home message. The second stage is severe placental insufficiency. When we call it severe placental insufficiency, when the umbilical artery shows absent end diastolic flow, or there is reverse in the aortic isthmus flow. That time we have to see a bi-weekly Doppler, and we have to deliver her by 34 weeks via a cesarean section, and we can give corticosteroids and deliver if she is less than 34 weeks. Next is the stage 3. It's a low suspicion of fetal acidosis, where the umbilical artery has reversed end diastolic flow. So we have to monitor every 1 or 2 days, and we have to deliver her by 30 weeks based on Ductus venosus PI. So if the Ductus venosus PI is more than 95th percentile, you terminate her pregnancy at 30 weeks by a cesarean section. If the Ductus venosus PI is okay, then we can give a course of antenatal corticosteroids and deliver her. The last stage is high suspicion of fetal acidosis, when the ductus venosus has reverse in A wave, when the C is computerized CTG shows less than 3 millisecond variations, and the last one is if there are active FHR decelerations on an NST or CTG. So we have to monitor her every 12th hourly and deliver her as soon as possible. So this is how we can prevent intrauterine fetal demise in cases of FGR, and this is the criteria, and that is the monitoring interval, and the last column depicts the gestational age and the mode of delivery. In the first case, you can go for labor induction, but the other 3 stages are an indication for cesarean section. And this is a very important diagram. So as already told you, that to manage an SGA fetus or an FGR fetus, we have to follow this flow chart. So so you will do a serial measurement of symphysiofundal height, or if they are suggestive of FGR, or based on history or biochemistry or uterine artery Doppler, if the fetus is at a high risk, you will do a fetal biometry. So if you do a fetal biometry, if an AC or estimated fetal weight is less than 10th percentile, it is an indication that you have to monitor and do a Doppler. So you will do an umbilical artery Doppler first. So if it is normal, you will repeat ultrasound fortnightly, and the umbilical artery Doppler and MCA Doppler after 32 weeks. If PI and RI are more than 2 standard deviations, end diastolic velocity is still present, then you will again repeat the ultrasound weekly to do the biometry, and twice weekly to do the umbilical artery Doppler. So if there is absent or reverse of end diastolic flow, you have to again do daily Dopplers to see whether it is deteriorating. If the Dopplers have remained normal, deliver by 37 weeks. If the end diastolic velocity is still present, then still you can deliver by 37 weeks. But if there is absent or reverse end diastolic flow, just give a course of corticosteroids and consider to do a cesarean section if less than 34 weeks of gestation, because the baby cannot handle the stress of vaginal delivery. So this is also the same thing. So stage wise assessment. So the stage of assessment, you decide the stage, you see whether what is her gestational age, and you decide on her mode and timing of delivery. So this is a typical progression of multi-visit Doppler studies, progressive placental dysfunction. So how does it happen? Firstly, the SD ratio gets elevated. Secondly, the MCA-PI falls less than 50th percentile, that is brain sparing effect. Then there is absent diastolic flow of umbilical artery. Then there is reverse diastolic. Then there is increased PI of ductus venosus. Then there is reverse venosus. Then there is umbilical vein double pulsations. And there is umbilical vein pulsations along with reversed A wave in the ductus venosus. So this is the progression of Doppler study. So you have to see where the patient belongs. And this is the timeline for fetal hypoxia to fetal death. So abnormal fetal growth, that is the estimated fetal weight less than percent, you can usually wait. If the abnormal arterial Doppler, you can again wait for 2 weeks. If there is abnormal venous Doppler, only 1 to 2 days. But if the BPP, that is biophysical profile, is abnormal, or if there is a suspicious or pathological CTG, that is, it's a pre-terminal event, and you have to take her up for a delivery based on her gestational age. So these are the timeline for hypoxia to death. So next, moving on to a very important other indication, that is fetal anemia. So as you all know, in RH pregnancies, especially in alloimmunized, what will happen? The babies is into fetal anemia because of the antigen antibody reaction. So this fetal anemia is best depicted in a non-invasive test. So before, we used to do amniotic fluid spectrophotometry, Lily's graph and or Mary's graph and all, but now we have the best investigation, that is middle cerebral artery peak systolic velocity. So as the increase in fetal anemia, the velocity to the brain also increases. So this is the principle behind doing an MCA-PSV in diagnosing the fetal anemia. So it means if the MCA-PSV is more than 1.5 median, multiple of median is 1.5 moms, then that means the fetus has gone into anemia, and it's a definitive indication for chordosynthesis. So to pick the correct hemoglobin of the fetus and plan for intrauterine transfusion. So middle cerebral artery peak systolic velocity. So we have to see what is the velocity in the brain to diagnose fetal anemia. So this forms the second indication for Doppler in obstetrics. So after understanding the prediction of preeclampsia, monitoring the FGR pregnancies, and to see the middle cerebral artery peak systolic velocity in cases of fetal anemia, we have to very much give importance to the practical aspects. So when you do a Doppler, it is entirely different. So what are these factors affecting color Doppler image are different things. So this Doppler angle, that is, I told you the insunation angle. So there is something called as PFR, that is pulse repetition frequency, gain, what should be the size of the color box, what are the wall filters, what preset should be set. But these are all very important practical aspects which has to be set in the ultrasound machine before you perform a Doppler. Otherwise, whatever results or whatever interpretation you do will be wrong. So that's why the preset thing should be correct, and whatever you're doing should be practically applicable. So this I will do when I practically show you how to do a Doppler on a patient. So this is the size of the color box, and what is PFR is the thing which is shown on the left hand side of the image, that is 2727. So that is the PFR. This I will be dealing in detail. So what are the take home messages? So I want to emphasize that Doppler is very important in our clinical practice. It is a decision-making tool when you come across an FGR pregnancy, or when you want to predict preeclampsia, or when you want to go and assess fetal anemia in case of Rh negative pregnancies. So that's why we have to understand the concept behind this Doppler and how we do a clinical application in a real-time situation. So thank you for your patient listening, and these are my references. Happy learning.